displays. There was a company called Accuray. I'd never seen them before. And they were marketing this machine, which is called a CyberKnife, and I'd also never seen or actually even heard of one before. It looked to me like a really interesting and exciting potential way of delivering radiotherapy. And the Accuray rep spotted my name, not my name, but spotted the fact that I was from the Royal Marsden, and he kind of honed in on me. And I remember saying straight away, look, I said, I'm the most junior consultant in the Marsden. You need to speak to someone more senior. And I kind of, I left. But after the meeting, I thought, actually, this is an exciting piece of technology. And cut a long story short, we ended up buying one at the Marsden. And there were a number of other things happening at the same time. So the Da Vinci robot was becoming significantly more widely used. We had Da Vinci robot at the Marsden. I think at the time we had one. I think we've now got three. And it was becoming the sort of more standard way that prostate surgery was delivered. It definitely wasn't in the UK at that time widely available. It is now. I'm not sure how quickly it was adopted in Canada, but definitely in the US, it was adopted fairly rapidly. And there were multiple trials comparing conventional fractionation, which would, in our terms, be 1.8 or 2 Gray fractions, to moderate hyperfractionation, which was in the region of 3 Gray. And there were a lot of these trials were recruiting at that time. And there was also the start of people starting to deliver SBRT to the prostate, which is 5 fractions. And at that time, a lot of it was, not all of it, but a lot of it was done on the CyberKnife platform. And it was tended to be done in relatively small numbers, and the series that were around were very low numbers, single center, but it was evolving. So when we got the CyberKnife, I was really keen that we tested it in a rigorous academic fashion rather than just start to use it, and hence we started thinking about the trial options. And PACE actually started as a CyberKnife only study, and it was funded by Accuray, and it was a group of Europeans from France, from Germany, from the Netherlands, and myself. We're all at Astro in San Diego, and we were thinking about what the trial options should be. And to be honest, we couldn't really agree. The Germans just wanted to do a surgical randomization. The Europeans weren't particularly keen on a randomized trial. Anyway, cut a long story short, I came up with the idea of doing both together. And the Accuray team said if I could get the others to agree, then they would fund the trial. And so this was essentially the outline. We wanted to test, at the time, what we thought was pretty low and intermediate risk disease. And the experimental arm was going to be 36.25 Gray and 5 fractions on both arms of the trial. And this was the design. So it was for men with localized prostate cancer who had low and intermediate risk. If they were choosing surgery as their primary modality of treatment, then they could go down the randomization of PACE-A, which is on the left-hand side of the screen, and the randomization was a 1-to-1 basis between surgery and SBRT. If they were choosing radiotherapy as their primary modality, then they could randomize in PACE-B, and that started actually as 78 Gray and 39 fractions, but evolved because of the publication of the hyperfractionation studies to a 4-week schedule of 62 Gray and 20. But both of the experimental arms were 36.25 Gray. PACE-C came a bit later, which was high-risk disease, and I'll talk about that later in the talk. And then also, which I will mention later in the talk, there is also now PACE nodes, but I'll cover that a bit later. So starting with PACE-A, so this was the surgical randomization. And although it's only recently been published, we presented it nearly 2 years ago, but it was published in European Urology a few months ago. So if you are interested, the full paper is now out. So just a reminder, it was low and intermediate risk disease, and the randomization was 1-to-1. And essentially, when we designed it, it was really a battle of the robots, because it was, at the time, it was CyberKnife only, and it was going to be robotic assisted, all laparoscopic, but most of them were robotic assisted. Prostatectomy, open prostatectomy would not have been eligible for the study. Patients had to have T1 or T2 disease, Gleason less than or equal to 3+4, PSAs less than or equal to 20. They were MRI staged, and importantly, no one in PACE A or B got androgen deprivation. And they were randomized 1-to-1. When we started, we did aim as an oncology outcome, but the numbers were never going to be achievable, and so we did switch it to a toxicity study. When we did the switch, we just felt that we should have co-primary endpoints. We always thought that urinary continence would be worse with surgery, but it was likely that bowel function would be worse with radiotherapy, and so we didn't want to bias the trial one way or the other, so we had co-primary endpoints, and we defined urinary continence as the number of absorbent pads required per day. And we, for bowel, it was epic bowel bother was the domain we looked at. So these were the characteristics. There ended up being 60 patients recruited in the surgery arm, 63 in the SBRT arm. They were predominantly intermediate risk patients. We are very proactive surveillance, so we treat very, very few low-risk prostate cancer patients. And the trial recruited 123 patients in total. So the results, and how we came to have the results when we did is when COVID hit, the recruitment to PACE A almost stopped completely because we pretty much put a halt on doing prostatectomies in the early time of COVID. And we ended up having a kind of almost 2-year gap of no recruitment. And the IDMC had a look at the data. That's our independent data monitoring committee. And they felt that recruiting another 10 to 20 patients was not going to be important because we'd actually, I didn't know that at the time, we'd actually already met our primary outcomes. And so we had enough patients, and they suggested we stop and publish and present the results. And what we found was the proportion of patients wearing urinary pads at 2 years for surgery was 50%, and it was 6% for SBRT. Obviously, these numbers are small, but that's and the urinary pad rate is perhaps higher than other surgical series, but that is what we found in the study. It is important to see how this changed over time. So obviously, soon after surgery, almost a very high proportion were wearing pads. That improved, but basically after about 9 months, there's not much further improvement, and there's not much change in time over SBRT. It's also important to note that across the whole study, men just wearing one pad accounted for 88%. So these aren't men who were dripping wet. They are, a lot of them, just wearing a one pad for security. But I still think it's very important information to discuss with patients so they understand that this is a possibility. So, it's a bit of Twitter fun. As many of you will know, Dr. Loblaw is highly active on Twitter. And what he said was, what I love most about the PACE A data is the expert urologist involved in designing the study estimated that only 15% of patients getting robotic prostatectomy that would wear a pad after surgery. And then popped on my slide from the presentation with his little emoji on the side and the reality. You can imagine this generated some response, but we haven't really got time to go through all of those. There was also one from my UK surgeon. The reason there's such a mismatch, basically saying because most men are just wearing one pad a day, which is true. So the answer, you can wear a thin pad and still have no problem. Oncologist response, do you use a pad just in case? I don't. Maybe what you call a trivial leak is so concerning for the patient he's wearing a pad. So a lot of this banter occurred after PACE A. Most of it was generally good-natured, but not all of it. So what about bowel function, the second of the primary endpoints? So this is an EPIC score. So a perfect EPIC score is 100. A very poor EPIC score would be sort of 20. So for surgery, bowel function was 97.3%, and for SBRT, it was 88.7%. So it was statistically significant. There was slightly worse bowel function for SBRT, again, not completely unexpected. And if we look how that breaks down, so most men had no problem at all. Those who did have a problem, that the majority were described as a very small problem. 12% with SBRT had a small problem, and 1 had a moderate problem. No one described as a big problem. And importantly, although this wasn't a co-primary endpoint, I think it's one of the most important things that patients ask me before treatment is what is the risk to sexual function? Again, a perfect EPIC score is 100, and you can see with surgery it was 26.5%, 26 not percent, the score was 26.5, and with SBRT 59.3. And if we look at that graphically, you can see that around about 70% of men had good sexual function before going into the study, close in both arms. A very big drop in surgery with some recovery over time, but it doesn't get close back to baseline. With SBRT, there's also a drop. It doesn't quite get back to baseline, but it's a lot closer. So those are just the EPIC subdomains at 2 years for both urinary incontinence, obstructive symptoms, the bowel subdomain, and the sexual subdomain. So Clive Pedell, he's a UK oncologist, again, highly active on Twitter, provocatively said, "This is the beginning of the end for prostatectomy and localized prostate cancer. In the future, prostatectomy should be reserved for patients with severe LUTs and large prostates. Patients deserve an honest discussion about PACE-A and the PROTECT trial and surgical learning curves." Provocative. Eric Klein, name would probably be familiar to most of you from the US. Nonsense. Prostatectomy has no long-term toxicity, and patients should be free to choose among the options based on what's important to them with respect to quality of life. Clive, no long-term toxicity, you are surely joking. And Eric goes on to say no radiation cystitis, no second cancers, and so on and so on. So clearly my view, I think it's important to have these honest conversations with patients. I don't think it's the end of prostatectomy. I do think we should probably be doing less prostatectomies, particularly as men are getting older, when men are getting older. And I do think that the PACE-A results should also be seen in conjunction with PACE-B, which I'm about to go through. So PACE-B, again, it is exactly the same eligibility criteria. So it's low and intermediate risk prostate cancer, and they're randomized between conventionally or moderately hyperfractionated radiotherapy and SBRT. And we were really pleased to get this published in the New England Journal of Medicine. We had quite a lot of debate about where to send this study. Andrew was very, very keen that we submitted to New England, and I'm delighted we took his steer and had a go. It was a bit of a labor of love getting it in. It took a long time to finally get published, but it's there. It was published a month or so ago. So just to remind you of the trial scheme. So this obviously was a much bigger study than PACE-A. So there were 874 men, exactly the same eligibility. And importantly, no one got ADT, randomized 1-to-1. So when we started, it was 78 grade, and that switched to 62 after the publication of mainly the CHIP trial. The experimental arm was 36.25 grade to the PTV and 40 grade to the CTV. So for the non-clinical oncologists, the CTV in this case is the prostate itself with no margin. And the primary endpoint was biochemical or clinical failure with a number of other secondary endpoints. So the baseline characteristics, the median age was 70, which is very, very standard for a prostate radiotherapy study. If you noted, I didn't actually mention it, the median age in PACE-A was 66, so a younger population as would be expected, but this is a very standard age for a radiotherapy study. The great majority of the patients in both arms were intermediate risk. As I said, we treat very little low-risk cancer, and large recruiters to PACE-A were Canadian centres, and I think the policy for active surveillance is very similar. So we didn't see a lot of low-risk patients in the trial. So in 2011, when we designed the study, the current NCN definitions of favourable and unfavourable intermediate risk did not exist. But I think it was 5 of the 6 reviewers from the New England asked us to break it down. Now, we couldn't actually do it exactly because it's based on a clinical stage, and we actually used an MRI stage. There is probably some stage migration, but predominantly on what we can provide, most of the patients were unfavourable intermediate risk. Importantly for me, the distinction is, would the men in PACE-A have been offered active surveillance today? A small proportion would. Some would accept it, some wouldn't, but we would still treat the great majority of patients who we treated in PACE-B with with radiotherapy today. So the results, so this was a non-inferiority trial. And what we found was that the biochemical control and clinical control for conventionally fractured radiotherapy was 94.6%, and for SBRT was 95.8%. Emma Hall, who is our lead statistician, when she phoned me before the results were out on the day they did the analysis, she said, before she told me the results, she said it's going to be very difficult to do another study in this risk group. So this was the event rate. There were, for the conventionally fractionated radiotherapy, there were 36 events, and for SBRT, there were 26 events, and that gave us a p-value of 0.04 for non-inferiority with a hazard ratio of 0.73. So looking at the toxicity, these graphs are quite busy. The top lines are the grade 1, the next lines are grade 2, and the bottom lines are grade 3. And the orange is for conventionally fractionated radiotherapy, and the blue is the SBRT. We were actually really interested in the grade 2, so I've just removed the grade 1 and grade 3. And this is GI toxicity up to 5 years. And you can see that those two curves are completely overlapping and actually very, very low rates of GI toxicity, which I must say I was really pleased with, because when we started this, I was worried that we would cause potentially significantly rectal toxicity, but we've really not seen that. This is GU toxicity. I'll again just show you the grade 2. You can see that there is a little bit of a curve separation between 9 and 18 months. And this, again, now that we've got more experience, is not that unexpected. With SBRT, you quite often get a flare of symptoms around this time. It tends to respond very well to prescription of an alpha blocker and is fairly short-lived. When you do treat them with an alpha blocker, it becomes immediately grade 2. So that is why it's recorded this way. But it is real. And I think it is, again, important that we discuss this with patients beforehand so that it doesn't come unexpected. For CT, CAE, GI toxicity, again, I'll show you the grade 2. Very, very low rates and no change between the two, no difference between the two. For CT, CAE, GU toxicity, very similar pattern to the RTOG, is a worsening between 9 and in this case, 21 months. But it then goes back down again. And at 5 years, which obviously we now have that data, there was no difference at 5 years. So again, we had a lot of Twitter activity. In fact, I was sitting at home when New England went live at 10 o'clock UK time. And at 10:01, maybe even before, I got the tweet plus email from Andrew Loblaw, and he was on there. First tweet was out, emails were out to everyone that we should be spreading the message. So Andrew has been a huge supporter of this from the start. But there was also a less fun side to the PACE-B Twitter response. I don't think you've kind of lived in Twitter long enough unless you've got a Twitter troll, and I've got a few now. This one, your study is a fail again. I'm so sorry. Why didn't you tell us the truth? And goes on and on and on about our results, and then gives a detailed analysis, huge statistical analysis, which was 100% and entirely flawed, not understanding the difference between a non-inferiority margin and hazard ratio. And this is what he was trying to explain. But yeah, a part of it got a little bit unpleasant. So what you really need in this scenario is you need a Twitter slayer. And unfortunately, I don't have one of these. And I have an absolute rule in my life because of my job as medical director of the Marsden. I don't ever get into arguments on Twitter. So I only say nice things on Twitter. I never argue with anyone. I don't have one of these, but I do have Clive Bedell, who can argue. So he went on to challenge this guy, Dong, and say why, get him to explain. And then he also pointed out he may need some help with his medical statistics, which was useful. So that's PACE A and B. Both those studies are complete and have been published. PACE C is the next study in the umbrella, and then PACE nodes. PACE C has finished recruitment. and the acute toxicity has been published, and I'll just go through that now. So basically, we're fairly convinced now that SBRT works for early prostate cancer. There doesn't appear to be a difference in the alpha-beta ratio for high-risk disease, which some people might have found a bit surprising, but there doesn't seem to be any evidence that there is. So will SBRT work for intermediate and high-risk prostate cancer? And the PACE umbrella is continuing to test these theories. So PACE-C recruited really, really well. We had a bit of a blip in COVID, but it carried on and picked up. And in fact, we recruited ahead of time, and we recruited approximately 1,200 patients. And that's despite the COVID pandemic. So there was some overlap in the eligibility between PACE A and B, and that was, between PACE B and C, which was planned, but predominantly this was a higher risk cohort. The big difference between the two studies was the risk groups, and everyone in PACE C got a minimum of 6 months of androgen deprivation. Some got up to 9 months. Again, that was a bit of a COVID phenomenon, but everyone got a minimum of 6 months. No one got treatment without androgen deprivation. And you can see the breakdown. So there's predominantly, this is the unfavorable and the higher end risk groups. It was very similar to PACE B. The volumes were slightly different. So in the moderate hyperfractionation, we included an extra centimeter of seminal vesicle. So the PTV itself got the 60 gray plus 3 millimeters, and then the proximal 2 centimeters. So the more distal end of the seminal vesicle got 47 gray. The very tips of the seminal vesicles were not included. And in the SBRT arm, the PTV again got 40 gray with a 5 millimeter margin and 3 millimeters posteriorly. And then the tips of the seminal vesicles got 30 gray as opposed to 36.25. So Alison Tree, who many of you will know, and has been a fantastic friend and colleague and works with me at the Marsden, and was actually involved in PACE right from the start, because at the start she was a research fellow. It's always great when you have a brilliant research fellow like Alison, who becomes a brilliant consultant and really just flies straight past you and is now an international superstar. So Alison presented the acute toxicity at ESTRO probably about 18 months ago. And what it showed was the acute GU toxicity. This is very similar again to SBRT in blue and moderate hyperfractionation in red. There was almost no difference. For CTA, CAE, again, you can see the start points are slightly different, obviously, because of the timing of the treatments, but again, very, very similar. So acute GU toxicity, again, for both grade 1 and grade 2, they were similar, with cumulative G2 toxicity of 27% versus 28%. Grade 3 toxicity was very, very low, 0.5 and 0.7% respectively. For GI toxicity, there was a slightly higher rate of GI toxicity, and this is probably a volume effect because we did treat a slightly bigger volume, but it wasn't very marked, but it again is real. So for GU, it was 11% for moderate and 13% for SBRT. And then the grade 2 worst GI toxicity, the CTAE, was 10% versus 17%. So there is a little bit of a difference. Again, the rates of grade 3 toxicity were very, very low. So this is our probably most famous Twitter troll. Sure actually who he is, but he's very, very active on Twitter, and he's basically slated every single aspect of PACE from the start. So when Alison presented this, again, he went on to say, similar to PACE B, the only question is how the team will misinterpret and spin the results in favor of SBRT, despite the fact that when Alison presented the results, she said exactly what I've just told you, and she told the audience exactly about the increased risks of toxicity. So, and then went on to say, I will continue to follow the evidence and do my best for patients. And thank God every day I live in a country which has the best healthcare in the world and not the NHS. Well, I think it's a matter of opinion. I'm not sure that the US can claim to have the best healthcare system in the world. We were also pleased to see that apparently we earn £30,000 per patient. Seeing we are salaried on the NHS, I'm not quite sure where that £30,000 per patient comes from, but if anyone knows, I'd be very pleased to receive it. So, although I'm not allowed to argue on Twitter, Alison was desperately keen to get involved. I had to restrain her. This was actually one of the talks she gave of trying to restrain herself from getting active on Twitter. She felt very offended by this. In terms of patient-reported outcome, so these graphs are the green. The green is no problem or very small problem, and then the lighter orange, it becomes small problem, moderate problem, up to red, a big problem. And then you can see how it changes over time. There is not a huge amount of difference in the patient-reported outcomes. There is a bit of difference at the 4-week visit for bowel bother, but not much difference at 12 weeks. For sexual function, again, there was no real difference between the two. Obviously, the rates of significant bother were higher in both. So what next? So we're now running a study called PACE Nodes. So this is in the much higher risk group. So all of these patients will get at least 2 years of androgen deprivation, or 18 months to 2 years. They're randomized 1-to-1 between prostate SBRT and prostate and pelvis SBRT. So this is 5 fractions treatment to both arms. So the way this differs from the rest of the umbrella is, in fact, the control arm was the experimental arm in all the other studies. And the experimental arm is the SBRT and nodes. So although I'm the CI of the PACE umbrella, Alison was the PI of PACE-C, and we've got Angela Papanathan and Sunil Jain, who did actually work in Canada with Andrew when he was a fellow, who are leading PACE nodes, and they're both doing a fantastic job. And the other person in the picture is Emma Hall, who's been our lead statistician and leader for the ICR clinical trials unit for all of the PACE trials. So PACE nodes is recruiting very, very rapidly. We had set a recruitment target of about, it was initially 470. It was recruiting so quickly that we actually had a trial TMG meeting and felt that we should really increase the power, because if we did that, it would be less likely we'd ever have to repeat a similar study. And we had an opportunity to potentially test other things, including some imaging sub-studies. So we paused recruitment, did a trial amendment. We went back to the funders and asked for more money, and they very kindly agreed to extend the grant. And so we have more than doubled the size of the study, and we'll be recruiting 1,200 patients. And I expect we will complete accrual by approximately the middle of next year. So it's going really, really well. And yeah, it just shows that you can recruit to these large studies, particularly in the NHS. So despite PACE A, B, and C, surgeons are still going to operate. And although I think people should have careful consultations, there will always be a role for prostate surgery. And so what are we going to be thinking of doing next? We do know that there is a failure rate. Even after outstanding surgery, you still get patients who recur, and some patients require salvage radiotherapy. So our next trial, which is currently in design, is called PACE Post-Op, or name has not been finalized, but essentially that's what we're looking at. And this is going to be a randomization between conventionally fractionated radiotherapy to the prostate bed, or the prostate bed and pelvis, and similarly, it'll randomize to 5 fractions to the prostate bed and the prostate bed and pelvis. Trials in design. We've got an international group put together who've started thinking about it. This group was going to be expanded. We haven't yet got a grant, so it is very early days, but I'm hoping that we will move on this early in the new year, and hopefully, all going well, have a grant next year and possibly open towards the end of the year. So we'll definitely love to have the Canadians on board, and we will, hopefully be able to have you back like you supported PACE B. That's it. I'll stop there.
Fantastic overview, Nick. Thank you so much. So the chat is working, everybody, or you can type your questions into the Q&A box. Nick, there was an earlier question from Urban, who's our medical oncology GU lead, asking about learning curves in PACE A. So I feel like the robot and SBRT we were pretty deep into the learning curves for both of those technologies. Can you have a comment about like whether we were still, these were experienced surgeons in PACE A, is that correct?
They were experienced surgeons. I've had, quite a number of surgeons say, this is just poor surgery. We don't have any other evidence that it was. The pad rate is higher than other series, but it was prospective, and the patients were asked the question, and they gave us the feedback. It wasn't to the clinician. We also, I didn't actually show you, but when we looked at the clinician feedback, there was absolutely no difference in the toxicity between the two. So if we hadn't done patient-reported outcome, we would have missed it completely. The pad wearing, because the numbers were small, if we had another 50 patients, that percentage could change dramatically. So I think what's important is continence rates are definitely worse after surgery, and patients need to be aware of that. Sexual function, I think we can now confidently say, is also definitely worse after surgery. Doesn't mean there is no role for surgery, but I think patients should be given that information, that is likely that there's a higher risk of some impact on urinary continence, and there's a higher risk of impact on sexual function. And when you put it with the PACE A results, the PACE B results, that show a 96% control at 5 years, I think it's very strong evidence that this should be considered by patients as an option. So I don't want to overstate our results. Their numbers are small, and therefore you do have to be careful of over-interpreting and telling every patient you've got a 50% risk of having a pad. I don't think that's necessarily the case. It is what it was what we showed. I don't think that's the risk across all surgeons.
There was a real world experience that came out of the UK with experienced surgeons using robots only, and it was similar, actually. So I think.
So the True North paper, the pad wearing rate in that was 35%, so a bit lower. But otherwise, our results are very, very similar. And as I say, I think, if we had another 10, 15 patients, we might have matched similar. And that's why I'm trying to encourage people not to get too hung up on the actual numbers.
Yeah.
I think the point is the continence is worse, sexual function is worse. There are definitely still patients. There are definitely patients I still refer for surgery. I think patients who are, 48, 48-year-old the other day, and he's going to have a prostatectomy, and I don't think it's the wrong decision for him. I think if you've got a 66-year-old who wants to be sexually active, I would say there's a very strong case to treat them with SBRT.
And I think most of us are in agreement that we all believe, I think, that multidisciplinary consultation before choosing their primary therapy is important, and really fact-based discussions about what life will be like afterwards. So Himaluka, as you probably know, is the head of GU in Hamilton, which is just west of Toronto. He asked, I don't know if you can see it, Nick, in the Q&A. He's talking about CyberKnife versus IMRT or VMAT. Remember that I think it was Allison's paper that came out showing a slight improvement in toxicity for CyberKnife.
Yeah. I'm conceived of. Yes. So we had a planned, as I say, when the study when it started, it was Accuray funded completely, and it was a sort of industry-sponsored trial. It was CyberKnife only. What then happened is the sort of funding situation at Accuray changed, and they asked us if we would take on the sponsorship of the study, which would significantly reduce their costs because they wouldn't pay per patient. I said I would do that only if we could open the study up to Linux. It was the best thing that ever happened to PACE. They provided us an unrestricted academic grant to run the trial. But we agreed at that time we would do a planned subgroup analysis comparing CyberKnife and Linac treatment. And we did find that both urinary and bowel toxicity were better. We've done a lot of work on why, and it's not easy to solve. And I think the reason it's not easy to solve is because often the way we test these things in a radiotherapy trial is in a planning trial, a planning study. The problem with this is that planning study doesn't tell you about the reality, because you can look at the doses that are static. What you don't know is actually what was delivered. And I think what it shows me is that where you put the radiation really matters. And the thing that CyberKnife has that the LINAC platforms didn't have in the trial was real-time motion management. So every single beam hit the prostate, and so the dose, you got within sub-millimeter accuracy. With the LINAC, even with rapid arc, if your prostate moves by 0.5 centimeter or 1 centimeter for 30 seconds while the beam is on, you could have a significant proportion of your dose going where you don't want it, and you'll never know about it. So, and you look at other studies now with MR LINAC. I think what it's showing us is that it's not the magic of any one platform or another. It's very simple. It's putting the radiation in the right place. And I think the thing that CyberKnife does is it does that very, very consistently because of the real-time motion tracking. The results, even without CyberKnife, are outstanding. I would not get up to anyone and say that you should only have SBRT on a CyberKnife, but it has been consistent, both in our acute toxicity and our late toxicity, that the CyberKnife toxicity was a bit better.
Perfect. A number of questions in the chat. So Patrick Chung asks, in terms of SBRT, is once a week or every other day or daily in PACE C? What's your preference, or what do you think is best for patients?
So we have tended to treat alternate days. We did start with once a day, and early on we found that seemed to be the acute toxicity seemed to be a little worse. Actually, when we've done the analysis, it's not that different. But our practice has been to treat alternate days. It's very, very well tolerated. I do treat some patients in a week. So we have some patients who travel. Most of our patients don't. We do have some who do. I'm very comfortable to do it in a week, particularly if patients have got minimal LUTs or anything to start off with. But our standard is alternate days.
Yeah, and we're the same. As you know, we did a study looking at every other day versus weekly. We started weekly because we were just afraid to cause too much toxicity. Acutely, we found more toxicity, although interestingly, Thomas Dilly's paper showed no difference between the two, and we're going to combine those. So look forward to that. Joda Cook asks about the very high and impressive freedom from failure rates, and compare that to Widmark, which is quite different. Do you have an explanation why the difference between those two?
Yeah, yes, and well, yes, to a degree. I think we have a more favorable risk group, although we have, as I said in the presentation, it looks like 70%, 76% unfavorable intermediate risk. That is based on MRI staging and not clinical staging. I think clearly, if you have a very palpable clinical lesion, you are likely to have a worse cancer. So I think we have a better risk group. I also think there has been an evolution in radiotherapy technology over the time. And as Widmark, who's legend in prostate cancer radiotherapy studies, did this so boldly before any of us were even really thinking about it, but really used very, very basic radiotherapy with bigger margins. So I think that makes a difference. So yeah, I think those are the likely things. Of the two, I think predominantly the risk grouping was more favorable.
I think the other variable that comes into play is you were looking basically at freedom from failure, and Widmark did biochemical disease-free survival. So passing away from another cause was counted as an event, and I think that may explain some of the delta between the two as well. Scott Morgan asks about, is there a subgroup of patients that you favor hypofractionation over SBRT, for example, those with a lot of LUTs or those with large prostates, seeing the differences that we did see at 2 years? Or you talked to everyone?
I mean, yes. And anyway, hi, Scott. It's patients with an IPSS score that's high. We use 18 as a rough cutoff. That wasn't a cutoff in the study, but we use it clinically. are patients I would prefer to treat with moderate hyperfractionation. I tend to try and optimize LUTs in every patient. If we've got a patient who's got marked LUTs, I really want the urologist to see and try and optimize them before we treat them, rather than trying to address it afterwards. But yes, those patients, look, at an exceptionally large prostate. I mean, I've treated a number of prostates with SBRT with prostates over 100, even up to 120. But if you're getting to a really large prostate, I would probably be a bit more cautious. But yeah, I think for me, the main issue is IPSS is the best predictor of worsening toxicity with SBRT.
There's a comment about, we have 5-year median follow-up, or just over 5 years with PACE-B. Is that too immature to recommend SBRT for younger patients? Or is it sufficient to fall back on some of the phase 2 experiences that a lot of us have?
Yeah, I mean, it's a good question. Again, what do you call a younger patient as well? We will be presenting the 10-year follow-up. We've got funding to present the 10-year follow-up. I expect, we will see a fall off in biochemical and clinical control. It won't be 96 at 10 years guaranteed. Exactly what it will be, I don't know. But I still think it will be very high. I don't think it's going to be game changing, so that you can say, oh well, we should stop advising it now because it's an entirely different outcome. So I think PACE-B, you can take it again with all the radiotherapy studies that have gone before. If you look at CHIP and all of them, yes, there is an ongoing failure rate between 5, 8, and 10 years, but it's really quite predictable. And so we will see an increased failure rate, but I don't think we're going to see a huge change in the toxicity at 10 years than we did at 5. And I don't think we will see an unexpected change in the failure rates.
So just as for John, we published our prospective studies going back 16 years, and we had 95% control for favorable intermediate risks at 10 years and only a 1% metastatic rate at 15 years. So I think the curves do kind of flatten out. I think the Breaky people felt like the wheels were going to fall off. I remember Kirk telling me, just wait, everyone's going to fail. You're going to have to salvage everybody, but it didn't actually turn out that way. Talk about focal boost. So DIL boost or flame type hyperfraction. Are you guys interested in that? Is that our new next domain?
So I was really interested in it. And we designed a small study, which we have actually published in the Red Journal, called SPARK, which we gave up to 47 gray to a focal boost. I'm probably a little less interested now because we've seen how good the control is with 40 gray to the CTV. I'm really keen on seeing the results of PACE-C because, we wouldn't have seen a high failure rate in this risk group. But if we do see failure rates in dominant nodules in PACE-C, then I think we up the ante again on the focal boost. What Alison's doing now with her MR-Linac work is actually looking at boosting the tumor in the gland and de-escalating the rest of the gland in a study called Destination. And I think there's a lot of sense in that, obviously, because, with the kind of results we're getting at the moment, it's really becoming more of a quality of life issue, so trying to optimize the toxicity, although it's low, it's not perfect. So trying to get even lower toxicity with the same disease control, I think there's a lot of merit in. So that's what Destination is going to be looking at. I think, look, we're not at the end of the road in prostate studies. Your team, Drew, have done a lot of work on 2 fractions. And I had thought that the next PACE study would be 5 versus 2. I couldn't get enthusiastic enough to randomize probably 1,800 patients to lose 3 fractions. So that's why we're looking at some other options for the next PACE trial. But I think 2 fractions is likely to become an option. Again, the MR-Linac work on a study called Hermes, which Alison, one of her fellows, presented recently at the MR-Linac Consortium, showed really encouraging early toxicity results for the 2 fractions. And you yourself, you've presented really encouraging results for 2 fractions. So I do think 2 fractions, somewhere between 2 and 5, I think is going to be the sweet spot. We all dreamt of 1. Most of us feel 1 is not going to be an option. The brachytherapy data that's out there really doesn't support 1 fraction. There are people doing it. Carlo Greco in Portugal. There are other people doing 1 fraction. I'm not impressed by the outcomes I've seen on the few patients who've had it. So yeah, I don't think 1 fraction is going to fly. Just remember that the last time I spoke at one of these, I was actually in Canada, and I presented one of our fellows' results of a 1 fraction study, which we were thinking about, it was probably 8 years ago now, but we haven't taken that forward, and we have no intention of doing 1 fraction.
I think 1 fraction, the Australians have published on it as well. It seems to be like a good palliative dose for an elderly patient, challenged transportation. But I think the failure rates are going to be significantly. Jared Morton's brachytherapy trial has now got 10-year follow-up, and there's about a 30 to 40% failure rate in the single fraction. Significant there.
It's not.
How do you guys approach patients with spacers? There's all these different tools we have in our toolbox now, whether it's still dose painting and whole gland de-escalation. I think that's one. What about spacers? How's that fit into your clinical practice?
So I'm not using them. And again, I look at the rectal toxicity we found was very, very low. So we have used some spacers, and we have got the space or trial running, which Vincent Koo at the Marsden is a PI on here. I have some issues with that study, and they have given 40 gray in the trial to the PTV rather than the CTV. So in my view, they can only increase the rectal toxicity of the control arm when compared to PACE, which maybe I'm being arrogant, but I think PACE should be used as the benchmark for what the toxicity should be. So, you'd have to tell patients that we are going to give you an increased risk of toxicity, which I don't feel comfortable to do. And the study is for 450 patients. I don't think that's anywhere near enough to show a reduction that will be meaningful in grade 2 toxicity when we're talking about rates at 5 years of 1.5% to 2%. So there's not a zero risk on space source either, although the risk of serious complications is very small. When they happen, they're pretty catastrophic. And I think if you have 1 grade 4 toxicity in 100 patients on something that's not really massively improving your outcomes, you've really got to question whether you should be using it. So yeah, look, it's become quite widely adopted in parts of the world. I've got colleagues in New York and in Florida who are putting spacers in on almost everyone. I believe in the US there is a financial incentive to do it. We are not routinely doing it.
Well, I think this is where this Bolton guy, this 5 UTR, he comes from. When I challenged him about if he dose escalates with standard fractionation, he admits he does. And I said, but you're causing toxicity. You know that from the RTG studies. And he told me to fuck off. So I think we understand where his allegiance and his motivation comes from. Just one comment about PACE-C in terms of the toxicity difference we've seen acutely. I noticed in your curve, we didn't measure CTC in the moderate hyperfractionation arm at 4 weeks. And could that potentially, the curves look pretty parallel, but there's one data point on the SBRT arm that's
it's because the data point starts
explaining it.
It starts 2 weeks after the end of treatment.
Yeah. So
yeah.
Maybe that's explaining the difference, because if you look at the 2 curves, they're actually kind of superimposed.
Yeah, no, it might be. I mean, we've tried all different ways of showing those curves, with no gap, with a dotted line. But yeah, I think it's as close to what we can glean that there may. Put it this way, I don't think there's a big difference.
No, I got you. We're interested in the PACE post-op, so let's chat offline about that. We'd be happy to help. The other question, it's interesting because I remember I was always like, why don't you just do SBRT? And you're like, can't do it. We have to get approval through NICE or NHS or whatever. But I noticed that if you look at Hashim Ahmed and the cryo and the HIFU, they have no problem offering that therapy. Is that because it's private? that they're able to offer it? Or like, why are the rules different for SBRT than these other ablative?
Don't get me started. This is NHS politics at its worst.
Okay.
For some reason, which I've never really understood, radiotherapy has been set a different kind of set of benchmark rules. Like the surgeons can do whatever they like. We have to have commissioning. I don't understand why. I mean, I've been to war with the NHS on this. I've won some battles. I've lost some. Even now with PACE, it's still not a routinely commissioned treatment in the UK, despite the fact that they asked for the data the moment we had the paper ready. They got the data at the same time as the editor of the New England, and it's still not a commissioned treatment. I mean, the good thing is most people are just ignoring the commissioners and just doing it now. So, but it'll become a commissioned treatment within the next few months. But yeah, it's why we are under different rules to surgeons. Someone else knows, but I don't.
Gotcha. Sorry to poke you on that one. One last question from Himu. What do you think of, do we need gold seeds on all these patients, or can we actually do, with the new machines that we have with the better CBCT imaging, like Ethos and Hypersight and things like that, can we get away without gold seeds?
Yeah, so in PACE B, about 70% of patients had fiducials, but not everyone. I think the answer is you can treat without fiducials. What matters is the radiation going in the right place. With fast treatment times, before and after before and after imaging, however you choose to do it, you need to be confident in your own radiotherapy QA that you are getting the radiation where you want it at the right time. We do still use fiducials, obviously, apart from on the MR Linac, which we are treating quite a few patients on that now. So we do still use fiducials. We do most of our SBRT on the CyberKnife. We have 2 CyberKnives. We don't do all of it on the CyberKnife, but we do probably 90%. But if you don't have those platforms and you don't want to have the logistics to put in fiducials, or you don't want to put in fiducials, you can still do SBRT. But I still think the important thing is you really need rigorous QA. You need to understand how you're delivering it, what your protocols are. I saw someone was arguing with us about a trial set up the other day and saying, well, they would accept a 15 millimeter shift before they, would call someone. I'm thinking, goodness, 15 millimeters, you're missing half the prostate. That's not the kind of QA you need if you're doing prostate SBRT. You need to be absolutely meticulous about the quality of your delivery.
Agreed. Thank you so much, Nick, for an excellent overview and quite a hearty discussion. I want to thank AbbVie, who sponsored today's meeting, specifically Nicholas Kugel and Donna Totten. It's been a real pleasure, Nick, and we look forward to future collaborations and changing the world again. Absolute pleasure. Thanks for the invite. I did look at wishing I was there, and then I realized just how cold it is. But actually, I'm better here. Perfect. Thanks. Have a great cheers, guys, everyone, and enjoy your weekend. Thanks, Nick. You too. Bye-bye.